Bismillah ar-Rahman ar-Rahim. I am Dr. Iyad Al-Rubi again with you in this genitourinary system infection. This lecture is very important because commonly you face this urinary tract and your genital system infection in your life. Actually, UTI or urinary tract infection is a very broad term that it can range from asymptomatic bacterial till very serious infection that can lead to sepsis. Epidemiology, if you can look to this slide, before the age of 1, males is more prominent here to have infection because of the foreskin and anatomical abnormalities. After age of 1 till the age of 65, the prominence in the female side as because also anatomical abnormalities, functional abnormalities, sexual intercourse in the age of 16 to 35. In male side, the prostatitis and prostatic the obstruction which is caused by prostate itself is an very important etiology. Older 65, men and female or male and female will have around, it is balanced infection, it is equal, around to be equal. Pathogenesis, first of all, how the bacteria will enter to the urinary tract or there. Ascending infection from periurethral bacteria. Hematogenous spread is uncommon, but it is common or it can be found in immunocompromised patient. Lymphogenous spread through rectal, colonic, and uterine lymphatics, direct extension from intraperitoneal abscesses or vesico or vesico-intestinal or vesico-vaginal fistulas. This is very basics. Host mechanism. The most common host mechanism is the continuously flow of urine because it is washing the bacteria. Urine itself has specific inhibitors for the bacteria. Host glycoprotein also inhibit bacterial adherence. Urethral chemoattractants like interleukins, specific serum or urine antibodies also there. There is normal flora of the periurethral area also, or prostate, like lactobacillus also provide defense against colonization of the bacteria. The zinc, which is found in the prostatic secretion, also functioning as antimicrobial agent. Bacterial pathogens factors, adherence, usually bacteria adherence property mediated by the ligands located in the roots of the fimbrias. There is resistant to the bacterial activity of human serum. Hemolysin, which is inhibit tissue invasion and making the infection available, or it is produce actually iron which available for the infection affecting pathogens. K antigen also prevent phagocytosis of the bacteria. The most causative organism, more than 80% E. coli, Klebsiella proteus, Enterobacter also, and Enterococci is less common organisms. Most common in pregnancy is beta hemolytic streptococci. In young ladies, staph, children, Klebsiella, Enterobacter. Hospital acquired infection, Pseudomonas, Staphylococcus, infection is common. Diagnosis of UTI depends on clinical suspicion, actually symptom signs, and simple lab, starting with simple lab studies like urine routine, which sometimes proceed to have to request culture. Proper specimen collection to avoid contamination, and if culture is indicated, to do culture as soon as possible. The gold standard for getting specimen urine sample is the suprapubic aspiration, and the second line coming transurethral insertion of Genitourinary to get a specimen or sample. But we usually are requesting clean catch urine sample, midstream urine. We are asking the patient to evacuate some of urine to the bathroom and then to collect the specimen or the sample of urine which needed for urine routine examination. The probability of infection based on single specimen, as you can see in this slide, suprapubic catheter is 100% accurate. Coming in the whenever the number of the colony or the bacteria found in the urine. Coming in the second line, as I told you, the catheterization, clean in and out insertion of Genitourinary catheter, but it needs more higher number of bacteria. And in the last, the clean catch, which we told midstream urine, which usually we need to diagnose the infection more than 100,000 colony. In urine analysis, we are looking for leukocyte stress, the enzyme which is secreted by this bacteria. Nitrate, you know, the bacteria converting the nitrate to nitrate is also another indicator for infection. White blood cells more than 5 in high power field, yani pyuria, and a lot of times we can see bacteria under the microscope. Sensitivity and specificity, as you can see here, the strays, nitrate, both together is more stronger. The white blood cells, all the above. Usually we are depending if you remember a report for urine routine examination and microscopic examination, we are looking for actually nitrate. We are looking for leukocyte strays. This is highly suggestive of infection. In microscopic examination, also we are looking for high white blood cells more than 4, and for the presence of bacteria. By that, you can put the diagnosis of urinary tract infection. Urine culture is not requested as a routine, actually. But it is important sometimes to detect the quantitative the quantity of the bacteria in the urine, Usually, the urine will be collected sterile container, should be cultured immediately. If not, it can be kept in the refrigerator for more than or up to 24 hours, let's say. You need to find in the culture greater than 100,000 colony to prove the to say this is a culture is positive. Here also same suprapubic catheter, the number, the probability of having UTI based on urine culture, the more than 99% will be there in suprapubic aspiration, in spite of having low colony count. The next, the lower sensitive is to get from the catheter or bilateral catheter to get the sample. And the last, the clean catch, it must be in male up to 10 power 4, and in female, or you can please remember that it is positive, strongly positive. It is more than 100,000 colony. Sometimes we used to localize the infection, right, left, from where it is coming, the bacteria. Sometimes we can do cystoscopy, doing cannulation of the ureter and taking specimen from left and right ureter. According to the localization of lower urinary tract, in the case of if you are suspecting sometimes prostatitis, semen culture can be done, or we can take prostatic secretions by doing prostatic massage. Localization study for these issues, we are taking first 10 ml of urine, which is reflecting the urethral microorganism. If there is microorganism, it will came from the urethra. Then we are doing taking midstream urine, which is belong to the bladder or representing bladder flora. Then we are doing a prostatic massage, taking some drops of prostatic excretions, or with that it will reflect the prostatic infection. And in the end we can take a sample. It will be both together, the prostatic secretion and the bladder urine which is coming from the bladder. If we'll go one by one, starting from the kidneys, acute pyelonephritis. We'll start with acute pyelonephritis. This is an inflammation of the kidney, the parenchyma, and the renal pelvis. Patient usually coming with fever, chills, and costovertebral angle tenderness. Lower urinary tract symptoms, dysuria, frequency, urgency, irritative symptoms mainly. And some patients can come with sepsis if he has this severe infection. If you will do lab investigation like these cases, you will find high white blood cells and sometimes higher red blood cells in the urine. Culture should be taken on the first presentation, on the presentation of patient, without delaying, to take initial urine sample and immediately to start antibiotics. As other urinary tract infection, 80% of this infection caused by E. coli, Klebsiella, Proteus, Enterobacter, the Pseudomonas, and others also is another microorganism doing pyelonephritis acute. The gram-positive bacteria also can play a role in this kind of infection. If we'll do CBC, there will be leukocytosis, high white blood cells, ESR and serotype protein also will be high because there is inflammation. Ultrasound is mandatory to be done in this condition to rule out obstruction. Why obstruction? Because maybe this is acute pyelonephritis with pyelonephrosis, obstructed infected kidney, and this is a serious problem that needs with initial management like antibiotics, IV, and fluids, supportive measurements. Also we need to relieve this obstruction as a cornerstone of steps to treat these patients. CT scan also helpful. Usually the kidney will be swollen. There will be sometimes perfusion defect because of the constriction or vasoconstriction in the peripheral arterioles. Isotope scan, sometimes it is not found in Gaza here, but it is detecting also perfusion defects. As you can see here, there is perfusion defect here. perfusion defect because of, as we told, vasoconstriction of peripheral arterioles. And kidney is, if you can see, it is swollen if you compare it to left kidney. Management depending on the patient condition. If it is the patient coming with severe infection, you need to take him in to hospitalize the patient, admit him, starting with IV antibiotics, resuscitate your patient, antibiotic, aminoglycoside, cephalosporins is very important. Usually you will give 7-10 days after parenteral antibiotic after relieving of the symptoms. And if patient is not is coming with mild infection, you can just give him 2 weeks of antibiotics in the form of fluoroquinolones or trimethoprim, sulfamethoxazole. Emphysematous pyelonephritis, it is necrotizing infection characterized by presence of gas inside the parenchyma of the kidney. Most of the patients with emphysematous pyelonephritis, you will find them have immune compromised patients, like 80 to 90% of these patients will be diabetic patients. Or the others, you will find obstruction in the urinary tract. Patients usually come with fever, flank pain, vomiting. Patient, you will find the patient sick actually in this condition. Pneumoturia may be present. Microorganisms will be E. coli, Klebsiella, and Enterobacter. By doing Cube X-ray, you can find gas in the area of the kidney. Ultrasound, CT scan also will find you will find same findings. Management is very serious, this disease. For this reason, you need, because the mortality rate will reach sometimes 50% in like these cases. And as I mentioned before, patients usually have comorbidities like diabetes mellitus or being immune compromised. First of all, if there is obstruction, you will relieve the obstruction. You will control sugar disease or sugar in the blood. Start to resuscitate the patient. IV antibiotics. Usually, IV antibiotics will continue for 1 month. Sometimes you need to do surgical drainage for this kidney, especially if it is obstructed, by putting a catheter or nephrostomy or digestent. Some patients will not respond to all these measurements, that you need to go further and do nephrectomy to save his life or her life. Chronic pyelonephritis, it is resulted from repeated urinary tract infection that can cause scarring of the kidney and atrophy of this kidney. And by the end, in the last, it will be impaired kidney or renal insufficiency in this kidney. Usually incidental finding by doing another ultrasound for something else, you can find a small atrophic scarred lobulated kidney. Usually these patients is asymptomatic. Most of these patients you will have has history of recurrent attack infections, especially in childhood mainly. If you will go further and do urine analysis, it will show leukocytes or proteinuria or not sometimes. Serum creatinine also sometimes being high. Urine culture also will not be positive, most of the time will not be positive. Ultrasound, IV, CT scan also will show same findings: small atrophic kidney and with scarring, with the clubbing of the calyces. DIMSA scan is very accurate in diagnosing this disease, because it will show the the scarred kidney, or the scarring of the kidney, and the split function of this kidneys. What is the percentage of participating in the function of the kidney? This kidney. This is an example of DIMSA scan. You have here in the right side multiple parenchymal defects, perfusion defect. For the same patient which is in the left side, that he has high grade of reflux. Management, there is no management actually, because the changes which happen to the kidneys is irreversible. Usually you will try to eliminate the infection, the recurrent infection, maybe by prescribing prophylactic dose of antibiotics. If there is any anatomical abnormalities, you will try, or functional problems, voidic problems, you will try to correct it. Reflux in children is very important to treat if it is there. Usually nephrectomy is not recommended or not needed for this condition, except if there is symptoms like hypertension which not controlled easily, or kidney with large stone that need to be removed. Renal abscess, also infection, acute infection usually leads with incomplete or inappropriate treatment. With inappropriate treatment, it can lead to formation of abscess, especially in immunocompromised patients. Here, perinephric abscess, renal abscess, it is the parenchyma, perinephric abscess within the Geroda fascia, paranephric abscess if the abscess extends beyond the Geroda fascia. Pathogens coming into by two ways: hematogenous and ascending. Hematogenous source, gram-positive, like staphylococci, coming usually this kind of infection being in the immunocompromised patient, diabetic patient, patient with renal failure and hemodialysis, drug abuser. Ascending infection, gram-negative is the most common, like E. coli, proteus, and this kind of infection being more in urinary tract abnormalities, whenever there is obstruction, infection coming up, and the microorganism, and can cause nephritis, which is kind of proceed to form renal abscesses. Again, presentation like pyelonephritis, fever, chills, flank and abdominal pain. Usually symptoms have lasted for more than 2 weeks. Sometimes you can palpate the kidney. In urine analysis, you can find white blood cells. If there is obstruction, you will not find white blood cells, high white blood cells in the urine. Urine culture also can be positive in most of the cases, but also around 30% of the patients it will be normal. Blood culture also sometimes 50% will be normal, and the others will not. Ultrasound can detect easily the renal abscess by having or appreciating an echoic mass with the kidney, or near to the kidney, or in the peripheral area of the kidneys. CT scan also is very important in diagnosing this by finding attenuation, focal hypotension in the kidney. QB IVB less sensitive. Here an example CT scan which demonstrates large perinephric fluid collection with ring sign. If you can see the peripheral, the capsule is hyperdense, that meaning this is like an abscess or abscess around perinephric abscess. And also we can find here the perfusion defect, that meaning this kidneys, the infection here started as pyelonephritis, then proceeded to form perinephric abscesses. First of all, supportive measurements, IV fluids, IV antibiotics, get urine sample for culture, and start empirical IV antibiotics. The second, if the abscess is small, the IV antibiotics will be enough for treating this infection. But if it is large renal abscess, you need to do aspiration, and you will get a culture sample for a culture from the aspirated fluids. Sometimes doing percutaneous drainage being difficult, especially if there is a lot of septations in this abscess, that needs open drainage of this abscess, and sometimes it can reach up to nephrectomy. Xanthogranulatus pyelonephritis, it is form of chronic bacterial infection of the kidney. Most of the time the kidney will be hydronephrotic and obstructed. It is pathological actually diagnosis, because it is severe inflammation and necrosis which proliferate the kidney and parenchyma. Usual patient can come with flank pain, fever, chills, persistent bacteriuria. In 35% of patients, you will have history of stone disease, kidney stone disease. Usually you can palpate a mass in the flank. Urine analysis, it can show high white blood cells and the protein, because it is a chronic infection. Anemia can be there. Inverted renal hepatic function test also can be there, because as I mentioned, this is a chronic problem. Usually unilateral. The microorganism E. coli proteus also can be the microorganism can cause the xantho. You will find it there. Anaerobic infection also can be cultured. Radiological examination, CT scan is the most sensitive. You will have large heterogeneous renal mass, multiple water density lesions representing abscesses and the calyces. Most of the time it can confuse you radiologically between the xantho versus renal mass. For this reason, most of the time you need to remove this kidney, and after histopathologic examination or report will come as xanthogranulatus pyelonephritis. Ultrasound also can show the large kidney. Here we can see large heterogeneous left kidney with dilated calyces and areas filled with lipid-laden macrophages. As you can see here in the white arrow, there is a stone in this kidney also. Most of the cases you will find a stone in these kidneys. Management of depending on the accurate diagnosis, as I told you, most of the time we can misdiagnose this pathology as a case of renal mass or renal tumor. Nephrectomy most of the time is performed, but actually, according to my experience, this surgery will be very difficult surgery, as the kidney being a stony, hard, adherent, fixed to the near all structures, that to dissect this kidney or will be very, very difficult. Medical treatment is there is some cases which reported, but it will not be curative. Most of the time you need to do nephrectomy, or at least partial nephrectomy. Pyelonephrosis, it is inflammation of the hydronephrotic kidney, or infection of obstructed infected kidney. It will cause supportive destruction of the renal parenchyma. This infection is very serious infection because of this obstruction and progressed infection, that it can easily progress this condition up to sepsis. If you remember, when we were discussing the pyelonephritis, I told you need to do ultrasound to rule out pyelonephrosis, because the obstruction in this condition is very serious. Imagine this like an abscess. You need to drain it, otherwise all the IV antibiotics or other measurements will not be function. Patients usually will come ill, high fever, chest, flank pain, lower tract symptoms most of the time will not be there. If bacteria or pyuria will not be there because of the obstruction, as I mentioned. Ultrasound is diagnostic. You will find hydronephrosis. If we will go to this is an example for ultrasound demonstrating a fluid debris level with dilated renal pelvis, which is suggestive of infected obstructed kidney pyelonephrosis. Management: you will start immediate IV fluid, IV antibiotics, broad spectrum antibacterial or antibiotics, and you will proceed to do drainage for the kidney. If the patient is sick, really sick, you prefer to do nephrostomy other than putting a double stent from down by doing cystoscope. Why nephrostomy is more appropriate for this patient? Because it is done under local anesthesia by intervention radiologist or by urologist, expert urologist. If we'll put dish stent by doing cystoscopy from down, we are using irrigation with pressure. That meaning you can push the bacteria to the bloodstream and fasten to or to make the patient to go to the bacteremia and sepsis fastly, to go fastly. Yes, for this reason we are preferring in sick patient to do only nephrostomy, percutaneous nephrostomy, other than to do digestant insertion. Bladder infection. It is infection of the bladder. Females is more than males of having this problem. It is mostly ascending infection coming from the periurethral and vaginal or fecal flora. Clinical diagnosis usually. Presentation and finding: usual patient coming with the voiding symptoms, dysuria, frequency, urgency, and nocturia. Low back pain and sorotic discomfort sometimes will be there, or most of the time will be there. Hematuria, cloud urine, also badly smelling urine also will be there most of the time. It can reach up to low-grade fever. In urine, you will have high white blood cells and blood. Urine culture usually not requested, starting with treatment immediately 3 to 5 days. But when but if the patient being sick or coming with recurrent attacks of urethra of this cystitis, we need to do urine culture. Most common organism: E. coli, Klebsiella proteus, and the gram-positive also bacteria can be a cause. For uncomplicated cystitis, like it which happening in the females, in female patients, usually this is uncomplicated cystitis because it is expected to have recurrent or urinary tract infection because of the short urethra. We can give nitrofurantoin, fluoroquinolones, trimethoprim. This usually we are giving 3 to 5 days only. Penicillin is not used usually because it is resistance. If these patients have recurrent attacks of cystitis, we have two kinds of cystitis here: persistent and reinfection. Persistent, the infection with same recurrent infection with same microorganism, which can give high suspicion of having a nidus inside the body that it can usually spread or split this infection or the microorganism. The infection usually coming from outside. If we are, as just I told you, if we are suspecting that there is a nidus or persistent infection, we need to do radiologic imaging, either ultrasound, IVP, CT scan, up to sometimes to cystoscopy to find or to localize the place that it is spreading this infection or this microorganism. When it is reinfection, usually we are evaluating the patient from outside, if something coming from the outside, or vesicovaginal, vesicoenteric flow fistulas. Management for persistent infection, removal of the nidus or the place that can be the cause of recurrent attack of this infection. When the infection is the cause, usually we are putting patients on suppressive dose, low dose of antibiotics for a long time, and actually this can function for 95% of patients. As alternative, self-intermittent, self-start antibiotics that patient can, whenever she or he, usually she will feel infection, signs of infection, she will start with antibiotics. If it is related to sexual activities while taking history, just you can instruct your patient to take 1 tablet of antibiotic after intercourse. In all patients which they maybe or usually they have atrophic vaginitis, as because of old age, it is actually found as an risk factor to have high urinary tract infection. Local estrogen ointments, creams will be there. Lactobacillus vaginalis suppository is also available. Prostatic infection, 10% of men symptoms consistent with prostatitis. Vast majority of this case of prostatitis you will not find bacterial infection, but usually you need to exclude it. This is the classification of the prostatitis. We have acute bacterial prostatitis, patients with which they are coming with acute infection, severe symptoms. This is acute prostatitis category 1. Chronic bacterial prostatitis, we have chronic bacterial prostatitis that also found bacteria. Will find bacteria in the secretion, prostatic secretion. We have also chronic abacterial prostatitis or chronic pelvic painful or pain syndrome. Usually this kind of infection you will not find bacteria in the prostatic gland. It is inflammatory process, but you will not find microorganism. This is the most common 3 types of acid prostatitis: acute prostatitis, chronic bacterial prostatitis, and chronic abacterial prostatitis, which the other name is chronic pelvic painful syndrome. From where it is coming, the microorganism usually coming from the urethra, ascending urethra, by refluxing the infected urine to the prostatic ducts. Usually the acute prostatitis is not common in pre-pubertal boys, usually affecting men who is sexually active or adult men. It is the most common urologic diagnosis in men younger than 50. Usually patients with acute prostatitis coming with fever, chills, arthralgia, myalgia, perineal rectal pain, and with severe urinary symptoms in the form of frequency urges, dysuria, voiding difficulty, up to urinary retention. In acute prostatitis, digital rectal examination, please do limited and very minimal superficial digital rectal examination, because if you will do proper digital examination, you can push the bacteria to the bloodstream and do bacteremia. And believe me, I saw a lot of patients on the examination table, they start to have the signs and symptoms of bacteremia. For this reason, if you are suspecting bacterial prostatitis, do very superficial digital rectal examination, and forbidden you will not do prostatic massage. In the urine, most of the time you will find high white blood cells. CBC will be leukocytosis. PSA not requested. Please don't request PSA in a patient you are suspecting that he has prostatitis, because it will come high, that it will confuse you and make troubles for you and for the patient. Why this is high? Don't ask for PSA, prostatic specific antigen, if you are suspecting prostatitis. Usually we can do clinical diagnosis, and we can start actually antibiotics accordingly. Prostatic massage, as I told you, it is not recommended in like these cases, because it can lead to bacteremia. Most common organism E. coli, other gram-negative, less frequent, like Proteus, Klebsiella, Enterobacter, Pseudomonas. The others is very rare. Radiological, we are not asking usually for radiological imaging or radiological workup. Management, antibiotics, empirical antibiotics against gram-negative bacterium, like fluoroquinolones, trimethamine sulfamethoxazole. Duration will be 4 to 6 weeks actually. It needs long time of antibiotics, because you know the blood supply for the prostate is not so rich. If the patient is sick in sepsis or near to go to sepsis, you need to admit these patients, do give IV antibiotics, supportive measurements, IV fluids. Most of these patients will have moon compression, like they will be diabetic, or they has long-standing of urinary retention with the catheters, comorbid, and this patient needs more serious management. If patient have urinary retention, we prefer to do supraoral catheter other than to do urethral catheterization, because more comfortable for the patient, will be more painful to be far away from the inflamed prostate. Chronic bacterial prostatitis, it is more insidious onset. Usually it is due to relapsing recurrent urinary tract infection. Most patients usually come with dysuria, irritative voiding symptoms, dysuria, urgency, frequency, nocturia, low back pain, and perineal pain. Some patients will be asymptomatic. Most of the patients, actually, some of patients will not have serious symptoms actually. They will have and like discomfort in the pelvis or in the perineal area. They will not be happy with doing intercourse, sexual intercourse. It can affect their libido. The findings usually we can find in the urine white blood cells, high white blood cells, or bacteria. CBC usually normal. PSA, we are not asking for PSA in these conditions. Digital rectal examination, most of the time you will find it normal, no tenderness. Usually we are doing the diagnosis by identification of the bacteria from the prostatic massage or secretions. The causative microorganisms is the same, E. coli and the others, but also sexual transmitted diseases also can be a cause, like gonorrhea, chlamydia, and the others. Also, the radiological images also not asked usually. Medical treatment, antibiotics, also it will be longer. Antibiotic therapy for sometimes 3 to 4 months, starting from fluoroquinolones. The response usually in these patients will take some time. Maybe the patient will stay going up to 4 to 6 weeks till he will start to have some response. Alpha blocker will make symptoms more less. If these patients have recurrent attacks of these symptoms in these conditions, we can do suppressive dose, give suppressive dose antibiotics like trimethoprim, sulfamethoxazole, and sulfamethoxazole low dose, nitrofurantoins, furantoin 100 milligrams or Cipro 250. In some patients you are giving everything and you will not have a good response. In that time you will do for him TRP surgery. Granitis prostatitis, I will skip this because it is not common problem or disease. I saw maybe 1-2 patients post PCG intravesical infusion because of bladder tumors. It is a granitis disease. Patient can come with fever, chills, and obstructive voiding symptoms up to retention, and CBC you will have leukocytosis. Digital rectal examination is very important. You will have hard indurated fixed prostate. Diagnosis, if you will diagnose granitis prostatitis, most of the time by doing biopsy. Treatment with antibiotic, corticosteroids, and sometimes TRP. Prostatic abscess also most of the time will be as a result of inadequate or inappropriate treatment for acute prostatitis, especially in immunocompromised patients, like diabetic patients, patients with on dialysis, chronic renal failure, patients which undergoing urethral instrumentation. Presentation also will come these patients with the same symptoms and signs of acute prostatitis. In the history, you will find these patients started, the condition started as acute prostatitis, responded first or initially to antibiotics, then the disease relapsed or became more aggressive. Usually, please, if you are dealing with a patient with acute prostatitis and you feel that there is no real response, no good response, start to redo ultrasound to rule out presence of this prostatic abscess. Digital rectal examination to have tender swollen prostate. Sometimes you can appreciate only in 60% of patients fluctuation. Here, and this is transrectal ultrasound, which showing hypoechoic lesions, which are giving high suspicion of prostatic abscess. Management: antibiotics therapy with drainage. You have two ways to drain these prostatic abscesses, either transrectal aspiration or transurethral by doing cystoscopy and doing de-roofing resection of prostatic abscess. Most of the cases, if diagnosed properly and treated, it will resolve without complications. Urethritis: infection of the urethra and inflammation of the urethra. Most of the time will be gonococcal infection or non-gonococcal infection like chlamydia or plasma, trichomonas. Most of these organisms transmitted, sexually transmitted organisms. Presentation: usually patient will have dysuria with urethral discharges. Obstructive voiding symptoms can be there because most of these patients with urethritis will proceed or will progress to have urethral stricture. Diagnosis made from culture of the urethra, swab culture of the urethra. 30% of these men affected with the Neisseria gonorrhea will have a concomitant infection of trichomonas. Management: the most essential management is prevention. According to the suspected pathogens, you will give antibiotics or antimicrobial drugs. If you are suspecting gonococcal, 250 milligrams IV ceftriaxone is enough. If not, fluoroquinolones like ciprofloxacin, of course, it will do the job. Non-gonococcal like chlamydia will usually are doing or using doxycycline twice daily for 10 days or 14 days, or azithromycin also is very good option for this condition. Epididymitis is infection of the epididymis. Most of the time it is ascending infection coming from the lower urinary tract. It is a common disease in patients younger than 35 who are they sexually active. And the most common organism in this age group is the gonorrhea and trachomatis, chlamydia. Children or old people, old men, most common organisms will be E. coli. Presentation: patients will come with severe hemiscrotal pain, scrotal swelling, enlargement, inflammation, with inflammation. Sometimes will have reactional hydrocele in the area by doing ultrasound. So most of the time you will find signs and symptoms of arthritis, cystitis, or prostatitis that is preceded this disease. By physical examination: large hemiscrotum, testis, matted epidermis to the testis, very tender, swelling or thickened spermatic cord. Urine will show high white blood cells and bacteria. CBC will be high. We are doing usually scrotal ultrasound, which can show enlarged epidermis, increased blood flow. Sometimes you find reactive hydrocele. And if we count this as acute scrotal condition, Usually you will or you need to differentiate between acute epididymitis or epididymolysis with torsion. Actually, you need to do ultrasound. In torsion you will have lost blood flow, but in this condition you will have increased blood flow in the affected site. If this pre-pubertal children get or got this epididymolysis, you need to do actually a detailed workup to see why this, because it is not usual, and you need to find out why this boys has epididymolysis. Maybe you'll find any anatomical abnormality that it can breed as a disposing factor for getting epididymolysis. Management: oral antibiotics, as we told, according to the age and suspected microorganism. Bed rest, scrotal supported or scrotal elevation. Non-steroid anti-inflammatory to relieve the edema and to relieve the pain. And accordingly you will prescribe the antimicrobial drugs according to the suspected microorganism. If the patient is severely ill, you will hospitalize him, giving IV antibiotics and IV fluid. If this condition progresses to have or to reach up to epididymal abscess, we need to do open drainage for this abscess. If some patients have recurrent relapsing epididymitis or scrotal pain, sometimes we need to do epididymectomy to relieve patient symptoms. Thank you.